It is 2 o'clock, and I would like to welcome you all to this session on chemsex around the world. But before we start, I first would like to acknowledge to the country. This conference is being held on the lands of the 5 tribes of the Kulin Nation, and we wish to acknowledge them as traditional owners. We would also like to pay our respects to their elders, past and present, and Aboriginal elders of other communities who may be here today. And having said that, welcome to you all, and also welcome to all the people who are joining us online. And I would like to introduce myself. We are doing a co-sharing together with Nia Dunbar. My name is Sjef Pelsser, and I'm working for Mainline Foundation, the Netherlands, based in Amsterdam. And I'm extremely proud to be the chair of this meeting, as I'm a person with lived chemsex experience. So I would like to give the floor to Nia.
Thank you, Sjef. Hello, everyone. My name's Nia Dunbar. I work for Reshape in London, UK, and we're also the Secretariat for the Chemsex Forum. And like you, Sjef, I'm very grateful to be here. Yeah.
But, of course, it's not about us. It is about these beautiful people over there. And we are still missing Dawie. I hope he is on his way. But shall we wait, Nia? Or?
I think Dawie's sorting out his presentation, but they're going to keep going.
Okay, so we keep going. Well, it's all about these wonderful persons next to me. And as you know, the name of the session is Chemsex Around the World. And I'm not going to spend too many words, because this means, in this case, we are going to talk chemsex around the world from Norway, Andres Lekanger, to Brazil, Karin di Monteiro. And then from there, we take it to Taiwan. And then, I have to check, Stephane Wen-Wei. And from Taiwan, we go to South Africa, to Dawie, who will be here any minute now. And then we wrap it up by stopping in Pakistan, and Yasir Ali Khan will tell us something about the situation there, and ending up with Canada with Yannick Gaudette. And Nia, you're going to speak about a bit of the practical stuff, right?
Okay, yeah. Hi, so I've just been asked to talk a little bit about the practicalities of the session. So all our speakers are going to present first, and they've all got about 7 minutes each, and I'll give you a little wave if you go over. And then we will open up to a Q&A, and we'll have a roaming mic in the audience for you guys. And also, if we have any questions that come in online, because this is being streamed virtually, we'll be able to ask those too.
Okay, then now let's go to the persons who are the most important in this session. And first of all, I would like to introduce Andres Lekanger. He has a bachelor's degree as a social educator and is a COB of Chem Friendly Norge. And I've had the pleasure to work with Andres in the past as well. Andres also works in the Oslo Municipality's Safe Consumption Room and Emergency Sleepover Service. So Andres, take it away.
I had no control. I regained consciousness while another was having sex with me. I blacked out and later came to myself when I reacted to someone else performing oral sex on me. This is what 27-year-old Joe tells Chem Friendly. Joe is one of 8 queer men or non-binary, some of them also sex workers. 8 users that have shared their stories about how being raped when they had chemsex, that they were filmed without their consent or given a drug without their consent. Or, as in Joe's case, it was simply difficult for the other participants to identify that he was not conscious. We've called the campaign Ask First, Sex Without Consent is Punishable. Each story has been given their own photo, and Hans, who experienced that the others at the sex party live published that they fucked him without him knowing it, his story has been turned into a movie where the drag king, Briar the Vaudevillain, reads up his story. The campaign is an example of what Chem-Friendly Norway is all about. We are a user and peer-led organizations for queers and sex workers who are affected by illegal drug use. We spread fact-based information online and on the queer nightlife scene on how to do drugs in safer ways. We hand out user equipment and work with patient advocacy, working towards the drug treatment sector so that they can be better at taking care of Chemsex participants who are in need of drug and addiction services. In addition to peers, we also consist of healthcare professionals. None of our communication is neutral or objective. We try to communicate both verbally and non-verbally in a way that shows that we are part of the groups that we are trying to reach out to. Ask First was initiated in 2021 by Chemsex participants who wanted to prevent others from ending up in the same terrible situations that they themselves had ended up in. The stories were collected in 2021 to April 2022, and all the participants have an ongoing offer to get psychotherapeutical follow-up if they need it. The stories are generalized to protect anonymity, and the campaign was launched 2022 during the summer Oslo Pride event. The pictures and the video was shared in social media by us and 13 organizations that are supporting the campaign: LGBT organizations, Sex Workers' Rights Organization, HIV Norway, and various organizations working with drug user rights and with harm prevention. Our communication is based on various studies that show that different groups of users respond positively to harm prevention advice adapted to that particular group. Qualitative studies and talks that we have with our users show that concern about rape is a recurring subject among chemsex participants. We have a broad definition of chemsex. In addition to methamphetamine, GHB, and methadone, we also include other amphetamines, MDMA, cocaine, ketamine, and psychedelics. We also felt that this campaign is relevant for the queer community as a whole, so we choose to include alcohol in the campaign. The goal is to get users from social media and over to the campaign's webpage, where they can find information about, well, they can find more stories, but also information about sex, drugs, and consent, about consent and the ability to consent, about rape myths, and also advice on how to avoid ending up being raped or on how to avoid ending up raping someone if you choose to mix sex and drugs. There's also advice on where you can get psychotherapeutical follow-up if you have experienced being raped or if you have raped someone else. So we got some critique that we are placing the responsibility for rape on the potential victim, since we're learning chemsex participants how to avoid being raped. But the users behind the campaign, the ones that have experienced these situations, they wish that they had had this knowledge before and think that they may have avoided being the victims of rape if they had had more knowledge beforehand. The campaign has also resulted in conversations with users that tell us that there is a rape culture in some, and I do want to stress some, not all, chemsex communities. We know that there are some sociopaths that plan to drug down and rape others, and that these perpetrators experience impunity because none of the victims are going to report them to the police because the victims themselves did illegal drugs. So who hasn't been raped by him? Chemsex participants that I talked to, and I mentioned one of these perpetrators' name, and then he asked me this question. This perpetrator is a dealer, and chemsex participants will contact him even though they know he might rape them if they're poor, addicted, and will have sex with him in exchange for drugs. This particular chemsex user that I was talking to told me that he would never tell anyone in his particular chemsex community that he had been raped because he would only be told that this is something that he has to expect. So a local newspaper wrote about the campaign, interviewing 2 of the campaign's participants, but we don't want further media attention. One activist working with substitute treatment for opioid users felt that lifting this issue is putting our chemsex brothers in a bad light. One way we are trying to fight stigma is to stress that this campaign is made by Chemsex participants themselves. And this is also how we try to fight stigma in general, by showing that Chem-Friendly's harm prevention work is driven by drug-using queers and sex workers. So we're going to keep on spreading the campaign. We have more social media material to share and are almost done translating it to English. Together with HIV Norway, we are contacting healthcare professionals that are handing out PEP and PrEP to see if questions about sex, drugs, and consent can be part of the standardized questionnaires that users have to answer to get PEP or PrEP. And when it comes to the known perpetrators who experience impunity, when it comes to these guys, Chemsex participants have started to do what sex workers have always done with clients that rape us. To share among them the perpetrator's name and contact information, their online nicks, and pictures. Chem-Friendly intends to continue lifting this conversation. Thank you so much for your attention.
Andres, thank you so much for this presentation on maybe one of the most difficult subjects to talk about within Chemsex. And for this, just to remind you, if you have questions, and I can imagine you have questions, save them for after all the presentations. So thank you for that. I think Nia told you already, but just to make sure. This also goes for the people who are online. Just put your questions in the app. Let's go to Karin de Monteiro from Brazil, from Sao Paulo, and I got the pleasure to have an extensive talk with you on Chemsex. Karin is a coordinator of teaching and research nucleus of Centro de Convivencia e de Lei. I have no idea if I pronounced that correctly, but I try. And that's in Sao Paulo, Brazil. She is a biologist, a PhD in sciences, neuropsychopharmacology. And Karin is identifies herself as a non-binary woman and a drug user. Karin, take it away.
First of all, I would like to thank you, Sjef and Nia and everyone here. I'm very nervous and I'll try my best. I came some information from what we are doing in Brazil. Nothing compared with all of you, which are more advanced in harm reduction and support to chemsexers. So we began in 2018. Since 2018, we have been familiar with chemsex concept and have been discussing it, but only after the COVID pandemic begins, people who inject drugs in health workers have come to us with specific and direct demands related to crystal meth use. It was the first time they came, actually. Chemsex practitioners began asking for syringe needles and information about drugs related to their sexual practices. And further, they came gradually with health and other specific demands, such as dental care, HIV prevention, PrEP, vaccines, and serious mental health suffering. Okay. On the other hand, health services in general are still not prepared to deal with these specific issues raised by chemsex practitioners. The use of injectable drugs in Brazil became gradually silent and in a very low epidemiological level within the last 30 years. So we don't have programs of syringe exchange, for example, anymore, nor medical professional training for it. In addition, the former federal government completely removed harm reduction from the drug policy in 2019. So the public health service have increasingly sought to develop new lines of care and prevention strategies together with experienced harm reduction institutions such as Adelaide, a drop-in center. We have been contacted by a range of other professionals as well, from academic researchers, digital influencers, sex parties organizers, infectionists, psychiatrists, journalists, all of them in the search for answers to the spectrum of health and social issues and suffering these people have experienced in Brazil. Despite an increasing interest in formal reports of chemsex occurrence, we see a lack of studies about the scene and its particularities in Brazil. We have today only 9 scientific papers about chemsex in Brazil. So as chemsex gains media projection, all these people, mainly users and harm reductionists, expect a coordinated plan of action from the government to prevent a new huge wave of HIV and hepatitis infection and death from overdose in young people. And in order to picture the scene and build a new line of care, we have started a project through a branch of actions focused on hepatitis prevention, screening, diagnosis, supported partially by the Ministry of Health, in which we offered HIV, syphilis, and hepatitis rapid testing in a range of drug scenes, from parties to streets, in order to access injectable drug users who are very hard to reach. From these actions here, we could access and talk about prevention, sex, and drug use with young people in parties, and offered needle exchange as a pilot action. And most of them had never been tested for HIV, hepatitis, or syphilis, to our surprise. And another aspect they bring is the fear of criminalization and punishment by other meth users or dealers, who are the only way to have access to the drug. So today we have only one user, one peer who works with us, Yannick. He asked me to say his name and present him. So I'd like to thank him for this contribution. And this fear from criminalization and punishment is the main barrier to even talking about meth use in Brazil. So we are currently acting on all these approaches, from education, doing training and course for our team and for health workers and for peers, research in collaboration with universities and with the health service, advocacy as well. We are calling authorities to include harm reduction again in the agenda of the prevention and combined prevention to HIV, and outreach actions with presential peer support, with rapid testing of HIV, syphilis, and hepatitis. We are building harm reduction kits as well and picturing the scene. 7 minutes, Karin. Okay, It's the last one. So we conclude that chemsex issue must be need to be approached by all these fronts. It's a very complex context. In Brazil specifically, we don't have this culture and the support for this kind of drug use. And I would like to thank all these workers who work with us in the field. A lot of people taking care of other people, and especially Raineri, Queer Core, which is the main protagonist of the chemsex with us. Thank you.
Karin, thank you very much for your presentation and especially ending up with the approach from different angles. So that's something which I really like very much that you mentioned that. From here, we go to, I thought we go to Stephane, but we go.
Stephane.
Yeah, I think we first go to Stephane. But if you like to change, that's fine by me.
No,
the slides, yeah, sure. I would like to introduce Stephane Wen-Wei from Taiwan. He's a doctor and specializing in infectious diseases, STIs, and HIV. His major research interests are chemsex, the LGBTQI community, and sexual well-being. And Stephane is also involved in PrEP implementation in Taiwan. Stephane, go ahead.
Good afternoon, everyone. First, I would like to apologize, like my slides are not very sexy today, so it's a little bit monotonous, I'm sorry. On behalf of my colleagues, I would like to thank the organizer to let us to present our research findings, and would like to share this with everybody today. So my topic today is experience of harm and mental ill health among GBSM who use methamphetamine or GHB-GBL in different combinations from our finding from our COMET study. So methamphetamine and GHB-GBL appear to be commonly featured as part of chemsex, often used in combination in many countries. So from our previous report, we found that 88% of Taiwanese GBSM who engage in chemsex had used methamphetamine, and almost 50% have used GHB-GBL in the last 6 months. And most of you have known that both substances act differently upon the central nervous system and can be associated with different harm due to their pharmacological properties. And polydrug, however, use has been widely reported in the context of chemsex, but there are very few studies have assessed the potential synergistic effects of mixed drug use. So our current analysis aims to examine the different health and social outcomes among GBSM in Taiwan who use methamphetamine and GHB-GBL separately or in combination. So COMET study, standing for Chemsex Online Survey for Men Who Have Sex with Men in Taiwan, is an anonymous cross-sectional online survey conducted by one GBSM geosocial network application. And we recruited our participants who are male, aged over 20 years, living in Taiwan, having had sex with men, and having used any substance during sexual contact in at least once in the past 12 months. So we collected different variables, including social demographic characteristics, sexual behaviors, HIV status, STI diagnosis, substance use, and also different harms such as physical, psychological, and social harm experienced after a chemsex session, as well as mental health indicators. The chi-square tests were used for descriptive statistics and also logistic regression for comparison of the risk factors. So these are the results. I'm sorry for such busy table, but there were 510 participants, including our analysis, and they were being categorized into 3 different groups. The first group, around 24%, used any substance except methamphetamine, denoted as M-, and around 37% used methamphetamine, but not GHB-GBL, denoted as M+, G-, and almost 40% of the participants use both methamphetamine and GHB-GBL, denoted as M+, G+. So from the social demographic characteristic, there are no significant difference. However, these three groups have some difference, significant difference regarding the rate of sexual partner number greater than 9, inconsistent condom use during chemsex, living with HIV, and STI diagnosis other than HIV, as you can see in the red box. So we further analyzed the different harm experienced by these groups, and we also found a significant difference among these three groups regarding all physical harm, psychological harm, and majority of the social harm experienced after a chemsex session, as also shown in a red box. So we would like to know that whether there was a greater chance that people are using more substance, or at least a combination of methamphetamine and GHB, GBL, will have a higher chance to experience these harms. So we further did these logistic regression, and we found that M+, G+, and M+, G- groups were more likely to experience different harms compared to those who did not use meth, M- group. After we controlled all these sexual behavior factors, and also polydrug and the frequency of methamphetamine and GHB, GBL use. And also we found a very interesting phenomenon that the risk of experience different harm follow a decreasing trend. So as you can see, there will be higher risk among M+, G+ group, followed by M+, G- group, than M- group. There are several limitations of our study. First, our participants were only recruited through one geosocial network application used in Taiwan. And the study sample included very few people who use GHB, GBL, but not methamphetamine, which is M- G+ group. So it actually might reflect the actual situation in Taiwan. However, in this case, we cannot differentiate the profile of people who experience harm in M- G+ group from M- G- group. There might be also other confounding variables, such as the participant's psychiatric diagnosis, a variable which we didn't collect. And it was not likely to know for sure whether men who have sex with men and were using methamphetamine and GHB, GBL in combination on the exact occasion that they experience harm after the chemsex session. So to conclude, our study found that the profile of the experience harm and mental health vary among groups of Taiwanese GBMCM who engage in chemsex using different combinations of substances. And the typologies of substance use and mixed usage may not only be key factor differentiating the experience of harm, but also the interventions that are required to support GBSM towards safer substance use and in the context of chemsex. I'd like to thank all the study participants and our community members who have been always supportive of our studies, my research collaborators, and also our research team. Thank you for your listening.
Thank you, Stephane, and for concluding that interventions and support is needed for this particular group to prevent them from more harm. From Taiwan, we travel on to South Africa. And I would like to introduce to you Dawie Nel. And Dawie is the director of Out LGBT Wellbeing and co-founded the organization in 1994. He has over 25 years experiences of working with and advocating for South African LGBT and MSM health and human rights programs. Dawie, it's a pleasure. Go ahead.
Thanks, Sjef. I'm going to talk about our experience of our HIV program, and within that how we targeted a specific substrata of chemsex users, and they are from Soweto Township in Joburg. For those of you who know a bit of South Africa, under apartheid, which was racial segregation, black people were forced to live in townships. And historically that was so, and the townships currently is also largely black people. Our organization is the second oldest NGO in South Africa. We've had various successes over the years. We opened the first MSM clinic in 1997. And in 2006, we led the campaign to secure same-sex marriage in South Africa. Our current programs are HIV services. We work in 3 cities, including city of Joburg, which is the biggest city in South Africa. We have a hate crimes and human rights program. We have a youth LGBT program, and we have some mental health pilot programs. Our HIV program is large, probably the largest in South Africa. It's funded by PEPFAR. Over the last 4 years, we've tested more than 36,000 men. We've initiated more than 10,000 on PrEP and about 2,700 on ART over the last 4 years. In city of Joburg, we have a fixed clinic, but we also have mobile sites in 7 health regions in the city that works on a daily basis. Some of the exciting new work that we've done in the last year, we did quite a lot, I think close to 3,000 community assessments of mental health disorders. Alcohol use, substance use, anxiety, depression, psychosis, etc. I think something that we did very well is we linked mental health, given the poverty levels in South Africa, with the process of finding employment. So we had a lot of cognitive behavioral therapy principles, but linked or with the focus of people securing jobs. We had various safe spaces and physical activities such as hikes, and we worked with the government in 2 of the shelters in city of Joburg to secure spaces for MSM. That's some visuals from our work, our clinic, our doctor. Those are some of our mobile teams. That's a bit of our online presence, social media, Facebook, etc. Then coming to the chemsex issue, our program currently is the only chemsex program in South Africa. We have 2 distinct target groups. There's a middle-class online grinder. I think maybe a lot of people are familiar with that. But what was quite interesting, and what I'm going to speak about, our program targets lower socioeconomic MSM, black unemployed MSM. Soweto, as I said, is a township in Joburg. It's largely a black area, almost exclusively black. There's widespread poverty in Johannesburg, the greater Johannesburg city. More than a third of people are living below the poverty line. There's many migrants in Joburg, which also really makes our retention of people in care quite problematic because they move on the whole time. Also, 4 out of 5 migrants in Joburg are from other countries in Southern Africa. So it's also cross-border, a lot of movement in the city. Joburg has got about 2 million people, and it's one of the poorer areas in Joburg, 6 times poorer than the richest suburbs in the city. That's some work from our chemsex programs, some of the groups and services we've provided. So it started in COVID during 2020, the Chemsex program. COVID was a bit of a blessing in disguise because we were forced to move away from larger groups to much more individual work and smaller units of work. By doing that, we sort of had a presence in communities for quite a long time. We got the trust of specific individuals, and through that we got contact of seeds. Now, how it works in Soweto, it's organized around drug houses. So a gay guy would own a house, and in the house would stay, like, let's say 4 to 5 other guys, and then men from the surrounding township go to this house for chemsex. Usually also for exchange of drugs and money, or money. So it is really quite a interaction of MSM, sex work, and drug use, all in one. The people staying in the house are usually quite dependent on the drugs. They're quite desperate for the drugs. Their sexual orientation identity is open for discussion. Of course, they have sex with guys for drugs, but they also sell their girlfriends, inverted commas, to get drugs. So they will do quite a range of things to get drugs. The guy owner of the house then also serves as a type of drug lord, and he supplies the drugs to the people in the house. There's been a move. The current most popular drug in Soweto is crystal meth. It's very cheap. It's about $2 for half a gram. And we provide in mobile services. Some of the results, since 2021, we've serviced 1,600 chemsex clients. If you look at, I gave an example of a retention, people who were diagnosed, initiated on ART, and retention in a 6-month period. As you will see from that, and which is for us quite a big issue, the retention. The HIV prevalence is around 20%, but we managed to only retain 45% of that cohort on treatment. There's also a very low uptake of PrEP. So for us, the next steps would be a need analysis to understand the drug scene a bit more, the health needs, the mental health needs, and food insecurity needs. I think we are very aware, I'm going to finish now, we are very aware of you can't talk about health needs if people's basic needs of food and security are not taken care of. So you need a hierarchy of services. You can't just have one level of servicing. We also need to really share and discuss more with other programs on how to better the retention in the program. And then there's a lot of socio-economic advocacy that we need to do. Also in South Africa at the moment, we're going to start doing work among sex workers and do it more under the umbrella of key populations and sexualized drug use. Thank you.
Thank you, Dawie, for pointing out that there is more to health than just health services, especially when we are talking about people from with lower socio-economic backgrounds. After Dawie, it is time for Yasir Ali Khan from Pakistan. He is a HIV-positive and chemsex activist in Pakistan, working for the well-being and advocacy of the harm reduction within the LGBTQI community, where drugs have been used for sexual purposes.
Thank you very much. I think most of the people feeling bored or sleepy. I'm also feeling sleepy. So the Chemsex is not very different from other countries and Europe countries, in Pakistan as well. People are thinking Pakistan might have no issue in the Chemsex and might have no drugs and these kind of things, but we have a lot of issues. So background of the Chemsex in Pakistan, in 2016 we didn't have the cases like overdosing and issues and crystal meth and these are some things. But after 2016 we have faced criminalization, killing people, each other, mental health issues, physical health issues, losing jobs and these kind of issues. Then we have realized, because that time we are just working for testing of HIV, testing of STIs and just treatment of HIV. Then we realized there's an issue with the Chemsex in the community, because I have been through this issue, and it was a phase of the dependence of the Chemsex and the addiction of the crystal meth. That time it was 4,000 rupees per gram. It was a little expensive, but now it's very cheap. So before 2018, even we did not know about the world of the Chemsex. So I met with Matt Southwell in 2018, and then we exchanged the things about the Chemsex in Pakistan. So even I didn't know that time the Chemsex, what is the Chemsex. So the major issues has been come about in the MSM and transgender community, and STDs are major issues of the HIV positives are coming, and slamming issues are increasing. Unprotected sex is going around, and the HIV is increasing badly, and the rates of the HIV in the Pakistan is increasing at that time. So the stimulant substance of the Pakistan is the same like the other countries. So we are using the crack cocaines, the cocaines, amphetamines, drugs, methamphetamines, MDMA, ecstasy, poppers, GHBs. Everything we are using it. So main method, same methods we are using it. Chemsex is equalized. Similar like other countries, we are using psychoactive substances for, especially in MSM and transgender communities and non-binary community. And we are using the crystal meth, cocaine, and which I've already mentioned. So we are using Chemsex in it. So this is a background. So, but Chemsex trend in Pakistan, we are participants reported that the substance and Chemsex opportunities were accessible through various venues, including dating apps, friendships, circles, and social media apps. These venues had integrated a groundswell of prospect of increasing engagement of Chemsex. So we are facing, we get the information and startup of the intervention in 2019 when I come out of the addiction and realize we need to work on the Chemsex. So we have started initially with the small amount of contribution and with the support of some friends in 2019, and we have started the sport groups, storytelling with each other, because that time we did not have any support from any organization and anyone. So then we have started the sport groups. We have started the outreach to community through the dating apps, through the friends links, and we have started we have made the pamphlets. I forgot to mention the pamphlets over here. So we have sharing that knowledge and started the peer sport without any support and fundings. So initially we did not have the funds, then we started the foods and small business plans with the contribution because the Chemsex participants, practitioners did not have the money. So we started to support them as well. So then fortunately we met with the Global Fund, and we have started in 2019 to put the funding in the funding request about the small amount of the Chemsex, and we are able to work. We are able to conduct a study in 2021. So it was a situation analysis of substance use and misuse among key MSM and transgender communities in Pakistan. So the study the aim was to know what is the situation around, to document what is the situation around in the Pakistan, because before that we have no any kind of data in Pakistan. So then I have conducted this research all over the Pakistan. We have identified the risk in the study: STIs, STDs, HIV, hepatitis, syphilis, dependence on mental health and stigma, discrimination, harassment, and anxiety or loneliness, and the drugs. So we are talking about the criminalization in Pakistan. So we have the usage of the drugs and to carry the drugs. We are criminalized, and along with the drugs to use in the MSM and transgender community for the same sex, 377 is implemented on our double criminalization, and if you are positive, have more stigmas. So the methodology was very simple. We get the data from national stakeholder research use manuals around, because that time we did not have the data, but we have get more information from national and international guidelines and get this information from the stakeholders around the globe in Asia. We have conducted an FGT national stakeholders, individual meetings with the UN team and government, as well sector the research, work, community mobilizations, mixed participations, quality and it's based on the qualitative and quantitative both. Yes, I have developed the questionnaire, which I've mentioned, which aspects I have included in, get feedback at the UN and revise the questionnaires. So the questionnaire, because most of the community is illiterate in Pakistan, so yeah, I'm going to end it. So. So we have included the English and Urdu questionnaires as well. So total participants we have included in 319, and 256 has been completed the English one, and 171 included filled with the Urdu. So yeah, so let me come direct to the results. So the 76% said we are using the drugs for the sexual purposes, and 24 hours said no, we are not using it. So it's a high number of the drugs using in the Pakistan. Meth is using most of them in Pakistan. So in the last year, they have shared 2016, they have started the drugs initially. So which I have also mentioned. As per the community response, they have said the crystal meth is most popular in Pakistan. So qualitative analysis was the fears they are bringing, the criminalization, experience of the being arrested. Yes, I'm going to add that. Thank you so much. So it's almost done. Thank you so much.
Yasir, thank you very much. And especially as you said, before 2018, Chemsex as such wasn't recognized, and already in 2019 you started putting up support services. So you are definitely applauded for that, as of course are all of the participants for doing what they are doing. And last but not least is Yannick Gaudette from Montreal, Canada. Yannick is a doctoral student in social work at the Université du Québec à Montréal, and his doctoral dissertation aims to better understand the effects associated with methamphetamine use in the context of chemsex among men who have sex with men. Yannick.
Thank you for having me today. I feel privileged to be here and share with you the perspective of people practicing chemsex concerning the harm reduction strategies they use to manage the potential impacts of chemsex. So for this presentation, chemsex will be defined as the use of specific psychoactive substances, which are crystal meth, GHB, GBL, ketamine, and methadone, by men who have sex with men, trans, and non-binary people to prolong sexual relation and intensify sexual pleasure. It is well established in the literature that at some point, chemsex can have different repercussions, like impaired social functioning, isolation, symptoms of depression and anxiety, psychotic symptoms, and contracting BB-STIs and/or HIV. But it is also well recognized that harm reduction initiatives are efficient to manage the potential consequences of chemsex. But we can see that the direct perspective of people practicing chemsex concerning harm reduction strategies hasn't received much attention in academic literature. One paper by Erichger and colleagues in 2020 focused on this perspective. So for this presentation, I would like to share and acknowledge the perspective of people using crystal meth in the context of chemsex concerning the harm reduction strategies that they use, but also the difficulties they face to introduce or maintain these strategies. The results I will share with you are from the PNP Within Diversity Research Project, a community-based research led by the Tradis Research Share based in the province of Quebec, Canada. Between October 2021 and June 2022, the PNP Within Diversity team carried out semi-structured interviews with 64 participants. Participants were all identifying as men, either cis or trans, or as non-binary, were all having sex with other men, and were using or used crystal meth. During these interviews, participants were asked about security and limits in the context of chemsex and their experiences with support resources. It is during these segments that participants share the harm reduction strategies they use when it comes to chemsex. As for the data analysis, members of the PNP Within Diversity team did a thematic analysis. A co-codification of 15% of the material was done in order to validate the classification of the data in the thematic tree, and inter-judge agreement obtained exceed the 90% threshold. So I have now shared on the screen the main results. As you can see, participants discussed individual harm reduction strategies, but also community harm reduction strategies, which can be described as practices of care, solidarity within the chemsex community. I'll take each harm reduction strategy one by one, which you can see in the middle table column, and address the difficulties of introducing or maintaining these strategies, which can be found at the right of the screen. First, participants named that they have been looking for information about psychoactive substances associated with chemsex, their effects, and potential consequences. According to participants, the information was either unavailable, and if it was described as alarmist, showing the difficulty to access accurate information on chemsex. Participants expressed that they try to have safer chemsex practices, mainly by using safe supply and practicing chemsex in safer environments, like their own place and with trust partners. But participants discussed the difficulty of accessing safe supply in some Montreal and Quebec City neighborhoods. We also have to consider that some participants using with trust partners start to use mainly alone, which could have consequences on their safety. Self-managing their chemsex practice was probably one of the main harm reduction strategies used by participants. To do so, they were planning the moment of chemsex session, managing the quantity of psychoactive substance use, and not combining psychoactive substances, meaning that they were only using crystal meth. Some participants described crystal meth as a substance that always brings their limits further, which made it difficult to respect their boundaries over time. For some, self-managing their chemsex practice became, at some point, impossible. Sexual health was a priority for the participants of the study. Still, some were facing difficulties to optimize their sexual health. It wasn't the case for the majority, but a few participants had difficulties getting PrEP because they were living in the countryside or because of their immigration status. Also, a few participants said having difficulties taking PrEP regularly, mainly during prolonged chemsex session. Accessing harm reduction psychosocial support was a strategy mobilized by participants. At the moment of the study, Crystal Meth Anonymous was the main resource for people practicing chemsex in Quebec. There is still a lack of harm reduction services in Quebec adapted to answer the specific needs of this community. Also, some participants accessed services to stop using crystal meth, and for some, there was a relapse. Instead of getting help according to a harm reduction perspective, some participants were excluded from a resource or a service, and this at a moment when they were feeling particularly vulnerable. I will now share the community harm reduction strategies discussed during the interviews. First, participants showed sensitivity toward other people practicing chemsex that were experiencing repercussions linked to this practice, like GHB overdose, psychotic symptoms, and others that need answers to some physiological needs. Facing the previous situation, as one of the participants said, the mood switched from fucking and taking drugs to taking care. And prevention of sexual violence is also an important community harm reduction strategy. Participants said that to do so, they were asking for consent from their sexual partner, always considering their partner's sexual pleasure. Some also shared that they were always discussing chemsex sexual practice and substance use prior to the PNP session, and others were strictly refusing to initiate partners to new means of administering crystal meth. The main difficulty associated with community harm reduction strategies is the possibility to talk about the repercussion, care practice, sexual violence, and sexual consent with professionals, as participants fear being misunderstood or even judged. People practicing chemsex might need to talk about these delicate situations as they can be lived as complex, affective experiences. So the originality of this research consists of the focus on crystal meth user and the consideration of the difficulties to introduce or maintain the harm reduction strategies. Key points of this presentation are that, first, the majority of participants use, at some point, harm reduction strategies. These strategies are not only individual, as there is some practice of care within the chemsex community. Indeed, the community harm reduction strategies highlight the social dimension of chemsex. Also, people who practice chemsex are willing to access harm reduction resources that are queer affirmative and chemsex affirmative. To lead efficient intervention with this community, professional needs to be aware of the culturally adapt harm reduction strategies put in place by the community and the difficulties to maintain them. Accurate information about chemsex, sexual health, safe supplies, prevention of sexual violence, and discussion around the potential repercussions and practice of care should be priorities with this population. And as it can be difficult for one service to answer the plurality of needs of people practicing chemsex, the collaboration between harm reduction services is encouraged to offer the proper support to the community. So I would like to thank the 64 participants of the PNP Within Diversity Research Project. Their contribution has been very important to have a better understanding of chemsex in Quebec. I also want to thank my colleagues, my PhD co-director and Trasis Research Share shareholder, Jorge Flores Aranda. Thank you to Harm Reduction International for organizing the conference, and thank you for listening. Feel free to contact me if you want to discuss the presentation. Thank you.
Thank you. Thank you to all our panelists. It was absolutely amazing. I felt quite emotional. Most of you I've seen over Zoom, and I'm used to waving at you and to see you, to meet you face to face, and I'm totally in awe of all the work you do. And thank you for sharing it with us today. Okay, so I was given timekeeping because I'm the bossy one out of me and Sjef. He's the better looking one, I'm the bossy one. And we wanted to keep to time, thanks everyone, because we want to open up to have enough time for you for a Q&A. We also, we have people online at a virtual session, so we're hoping that their questions are going to pop up too on Sjef's phone. We haven't quite worked that bit out yet, but we're hoping going to be able to see it. So in order to make the most of this Q&A session, the organisers have asked if you do have a question, if you can raise your hand. We've got a roaming mic at the back that will come to you. And they have asked if you can identify yourself briefly and then ask a focused question to a particular panellist. We're going to take 3 questions at a time, so I'm going to try and write them down to remember as well. Not every panellist has to answer, so don't feel on the spot or obliged if you don't want to answer a certain thing. And also have been asked if one of your questions turns into a statement, then it is my job to remind you that it is a question to a panellist. So don't shout at me if I do that. Okay, so let's open up to the Q&A. So please raise your hands. I'm sure there's some great questions for the panellists here. Don't be shy. Mac. Great, thank you.
Thanks. Hi, everyone. My name is Mac. I work for Mainline. I'm a colleague of Sjef's. I was really interested to hear the presentation about consent and basically sexual violence in the chemsex scene. I also wondered how you deal with the perpetrators, because you mentioned in your presentation that it's often sort of that other person, a sociopath you mentioned at some point, but it's of course also often people that switch roles, that might not know that they're crossing boundaries. So I was just wondering in your campaign how you're dealing with that. Thank you.
Thanks, Mac. And if we take another question or another 2 questions just now, and then we can respond to them. Can you see any online? No. Oh, there's one over here.
Thank you. I'm Adam Bourne from La Trobe University. I had a question for Yannick. I really enjoyed your presentation, and a colleague and I were just reflecting how valuable it is to have that granular level of detail around harm reduction strategies that can be employed by people engaging in chemsex and utilizing crystal meth. I just wondered whether in your study you collected any data about how we might reshape some of the community level discussion around chemsex and in tackling the stigma that is associated with discussions of drug use that still exists within queer communities as well, and just any reflections on if and how that came up in your data.
Thank you, Adam. Oh, and one more right at the back, Mr. Ben Collins.
Hi, Ben Collins with Reshape. Thanks so much for your presentation, Dawie. I thought it was really amazing, the work that you've been doing in Soweto. You talked about both the middle class work that you're doing and the work in Soweto. I remember when you told us about it before, that there was really no internet action in Soweto, that it's all face-to-face and in the group. Is there any kind of dynamic between those two groups, people outside of Soweto and people inside of Soweto?
Thank you. Thanks, Ben. So if we go in order, so we'll go to Andres first, then followed by Yannick, and then to Dawie, if that's okay. Thank you. Take it away.
All right. Thank you for the question. So if I understood your question correctly, it was how we deal with perpetrators, and that is a common experience in chemsex that people have both been the victim of rape and also raped others. So how we deal with perpetrators? Well, raising awareness, because that's basically the only thing we can do. These people, nothing will happen to these sociopaths unless somebody actually reports them to the police. It is on our agenda to get contact with the police, and we are contacting both like queer politicians who can help us get in that way, but also the biggest LGBT organization. They have their own group working with police liaisons. So to address the issue of people being afraid of reporting crime to the police, because then they themselves will incriminate themselves. So basically raising awareness. And when it comes to that, it is a common experience that people have been both experienced being the victim of rape, but also being the perpetrator. This campaign isn't out to get anyone, and we write it in the webpage that everyone deserves help. So that's why you can find help if you have experienced rape, but you can also find information on where to find help if you have raped someone. Because, okay, we know that there are these few that we would describe as sociopaths, but we believe that most people that rape do it because they don't have any better knowledge. So we're not out to get anyone with this campaign. We're out to just raising awareness and hoping that will do the job over time. Thanks.
Thank you.
Thank you for your question, Adam. In the data right now, because people were talking about their experiences, we couldn't go really any further concerning the community harm reduction, but I will answer as a social worker, because I'm also a social worker with the community, with people who practice chemsex. And when we show an understanding of first, like, gay culture, queer culture, when we show a comprehension of what it is to participate in chemsex session, it is much easier to do some prevention actually with the community, even with people who do not practice chemsex, actually, because they probably have been exposed to this practice before. So just having culturally adapted intervention is, I think, the key here.
Thank you. And to Dawie, please.
Okay, thanks, Ben. I mean, the men in Soweto are primarily offline, and it's based around these houses. Of course, you know, it's not necessarily either or. They could also have an online life and interaction. But usually with poorer MSM gay men, they use lower data sites. Like something like Grindr is quite data heavy because it's got pictures and so on and so on. So there's also a range of sites that they use that is text-based that doesn't eat that much data.
Thank you. Okay, we'll go again. Any hands, please, for any questions? Thank you.
Thank you. My name's Nikki Bath. I work at LGBTIQ Plus Health Australia. I just wanted to ask broadly of the panel, but in relation to sexual assault, like we really struggle here in Australia because the context of sexual assault and where sexual assault sort of occurs within relationships for us sits in the National Plan to Reduce Violence Against Women and Children. And so we really struggle to get the issue on the agenda at a policy level. Just recently, a grant has gone out from the federal government to look at, different in this context, but just give you an example of looking at sort of online abuse, and that's then targeted at LGBTQ women and cisgendered women, but then we're not seeing a place for that then for trans men, non-binary people, and cisgendered men. So I just wondered in your countries what the context of how that gets managed, how that looks in some of those countries. Thanks.
Thank you for your question. Any other hands? Oh, thank you for running around for us.
Hi, thank you. My name is Yudil, academia from Indonesia. I have two quick questions for two speakers, if you don't mind. The first one is for Mr. Stephane about the study. And the study is focused on methamphetamine and GHB, but you also showed that you also assessed mental health conditions. And you showed about depression and also suicidal ideation. And assuming that if you took data on psychoactive substances, did you see any correlation with mood-altering substances that being used as antidepressants as well, such as ketamine or benzodiazepines? And my second question is to Mr. Yasir from Pakistan. So I can only imagine how difficult it is to conduct harm reduction in a very conservative Islamist society. In Indonesia, I went to Aceh, which has a Sharia law, and harm reduction is almost non-existent there. And it's very, very difficult to reach, especially for females, because they experience a really harsh stigma there. So I'm wondering about, so you conducted this study, both qualitative and quantitative, and how do you plan to discuss this or advocate this to local religious leaders or imams in Pakistan to smoothen the, maybe like anti-stigma strategies? Thank you so much.
Thank you. Was there another question? Yeah. One more here. Thank you.
I have a question for Stephane. I personally from Hong Kong, and Taiwan is, I have to say I'm very jealous that Taiwan is the first country in Asia that legalized same-sex marriage. And having an Asian background, and I know the Asian culture has been very tiptoeing around homosexual issues, and on top of that, we're talking about like very controversial topic within the Asian culture, which is drugs. Do you think it is more difficult to raise awareness within the Asian community and the Asian because of the Asian culture than the Western culture, which already like drug is like a more like dare I say like a trendy topic these days anyway, but in Asia it's still a very controversial topic. Yeah.
Thank you for your question. Okay, so if we go first to the question from Nikki around sexual assault, which was to the panel. I'm not sure, maybe a couple of you would like to comment on that? And then, thank you, and then afterwards we'll go to Stephane, and then we have a question for Yasir, and then back to Stephane again. Thank you. Yasir, would you like to comment? Yeah.
So when we are talking about the sexual assault, so Pakistan always have these kind of issues with the sexual assault, and also when we are stuck in the Chemsex, it happens more. But when we are coming, the sexual assault community come to our organization. It was the Hope organization is working for the ICJ. We recorded the cases, and we try to support them with the laws, with the lawyers. So but recently UNDP also created a team of lawyers who supported to LGBTI community for the sexual assaults or these kind of issues, and especially in the sexual harassments and these kind of issues. Yeah.
Thank you, Yasir. Anybody else?
I can answer quickly that Concurrent is a small organization with limited resources, so we haven't really started taking it up to a political level yet, but we should, since there is obvious consequences with the drug laws. Prohibiting people to going to the police, but our strategy has been to start targeting like healthcare professionals and putting it into our patient advocacy work with healthcare professionals because it is a difficult topic to raise among Chemsex participants. We were thinking, okay, but the healthcare professionals who are meeting the Chemsex users can be a way in, but. And we were very happy that there was a broad cooperation around our campaign with all the LGBT organizations, because they have better networks into the political leadership when that time comes. Thanks.
Thank you. Okay, well, do you want to comment on that one, Stephane?
Yes.
Yeah.
So in Taiwan, we do have a general law protecting victims for sexual assaults, not just LGBTQ, but mainly also women. But to be honest, like among the Chemsex users, we have seen these phenomena from time to time. It's not just limited to people who are using crystal meth or the typical Chemsex drugs, but also alcohol. Actually, I think alcohol is the major problem. So in our harm reduction brochure, we do have these kind of sexual consent and also these kind of information to provide. But to be honest, when it really happens, we need to refer them to LGBT-friendly lawyers to deal with that. But it's definitely a very important issue. I think if we are going to do more survey in the future and also like research, I think we all need to put that in the context.
Thank you. And I'll pass back to you again, Stephane, with the next question, if that's okay. Thank you.
Oh, no worries. So I think this is a very interesting question, because we all know that ketamine has been approved as one of the treatment for suicidal, like a severe depression and suicidal attempt. So unfortunately, we did collect data on use of benzo and also ketamine, but we haven't done this analysis yet. But to be honest, there are not a lot of people using ketamine nowadays. The majority of drug that people use in Taiwan is actually crystal meth. So thank you for the question. I think we would love to see these when we get back. Thank you.
Thank you. And over to Yasir.
Thank you very much for asking this question, because Nia did not allow me to continue. It was my last slide, and now I can speak.
He loves me, right?
Actually, LGBTI community is not acknowledged in Pakistan. We have the Act 2018 of the Transgender Act, which is very famous in the round, but we always kick back from Islamic conservative natures and Islamic mullahs and scholars. So we never speak with them about these issues, because they are into these issues, but they are involved totally. But whenever you go to them, they always said, "Oh, this is haram. This is a Sharia law. Do not allow you. Otherwise, we cannot start with the harm reduction work as well." So we are trying to be a modern country as well. But Islam is not a. But Islamic scholars always create an issue. In my study, I face some issues, but because I'm very popular in my community. Due to the Chemsex, some negative impact or some might be positive, maybe because a positive person, also a Chemsex user, also very many bad issues. So I only connected with my community for the research, and so I have conducted the data and qualitative and quantitative, and it happens. Yeah. Thank you.
Thank you, Yasir. And there was one more question for Stephane around the controversial topic of drugs in Asia.
Yeah, I think talking about sex and drugs is always a taboo in Asia. Actually, it's not really only in Asia. I think many different countries it is the same thing. So, like in Taiwan, we especially for us, we are like advocates. We are actually using different strategies, like facing your target. For example, if this is your communicating with the community, then we definitely can use fun, like much more fun, sexier contents. But while we are dealing with, talking with the stakeholders, for example, the fundraising from the government, also corporations, we were kind of using a different way, mainly on human rights, marginalized population. But we're actually not facing just a stigma outside the community, but also inside the community. So within the community, there's always like stigmatizing opinions on make drugs. So I think being inclusive is one thing. So we try to always not judging others and try to, when we do all our campaigns, we try to include all, for example, ethnicity or appearance, like and all like characteristics. So we just want that our company is not just monotonous. It's not just like we are advocating for one kind of GBMC, for example. We are trying to bring the diversity. I think it's something, the key concept that we're keeping using for the past few years. Thank you.
Thank you. I just wanted to say, if you are listening online, don't know where the camera is, I do apologise if you've been asking a question. It's not showing up on the app, so I'd hate that we missed any. Hopefully you've heard maybe somebody ask it in the room. We do have time, if you have a burning question, maybe for a couple more. If there's any hands. There's a hand here. Sjef.
Karin, I know a bit of the situation because we talked about it beforehand, but you were talking about that a lot of different disciplines ask advice on chemsex from your organization. And I can imagine that you do not have like 30 people staff who can go into that. How do you deal with all these information requests?
Thank you, Sjef, for the question. We have 15 persons in the organization doing all the jobs and roles. So we are facing very hard times and difficulties to work with chemsex. In 2023, we haven't make any action on chemsex still now, direct action. We are meeting other people from the government and doing advocacy and planning projects, but we are out of the scene this year because we have till now no funds to do it. So we are searching for new funds. We have a new government now this year, and we are hoping things will get better. So that's the scene right now. And we have one peer who works with us, and he's waiting for a position or a possibility to work, and we continue our investments. So is that what is happening now?
Thank you. Okay, so just to end this Q&A session, can I invite the panelists to give a final brief statement, less than a minute, and then I'm going to hand over to Sjef to close. Thank you. If there's anything burning you'd like to say to close the session.
Anyone? Well, just thank you all for being here. I would just actually was thinking of being bold to take the mic anyway and say that if you like our campaign, if you check out Ask First, and the amazing graphic designers are sitting there, and they're having a presentation tomorrow about their amazing work. So thank you.
Stephane, go ahead.
Because I'm ID doctors, and it's not really related to what I present, but I think we are really facing emerging infectious disease all the time, and we had experienced COVID, and in Taiwan there was that people are being marginalized, especially people using chemsex are being really marginalized because of COVID, and now we are facing mpox in really different parts of the world, and so I think. Also, we're already seeing that in Taiwan that people are doing chemsex were really suffer from this. So I just want to advocate that, I think this is also part of the harm reduction facing all these emerging infectious diseases, and we all need vaccination available. Thank you.
So, who would like to take the floor for the last? Go ahead.
I think this is a crucial time because epidemic, especially in the Asia, the epidemic is increasing badly of the HIV, especially in the MSM and trans community and non-binary community. So I think Asia really do not know much about the chemsex, what is the chemsex and what we have. So I think we all collaboratively works together, and because this is not a matter of one person, this is a matter of the humanity. So this is my last message for please support to chemsex youth practitioners and do not discriminate us. Thank you.
So, Karin, Dawie, Yannick, any last words from you?
If I have to say something, I think for me it's really just important to acknowledge socioeconomic class as a variable in chemsex and how that changes reality and needs, and also to develop best practice on a hierarchy of programming, that it's not just one thing, but if you use Maslow, it starts at your food security and it moves up. So I think that's really important.
Thank you, Dawie.
The only thing I would like to say probably at this point is that we can see now around the globe that there is sadly a rise in homophobia, transphobia, queerphobia, and this will have an impact on the practice of chemsex. So the work we're doing here and the work you are doing in your organization actually is important. So we gotta keep the work going. That's it.
Thank Thank you. Karin, would you like to have a few more words to finish this?
Thank you once more, and I would like to agree with you. We have some in Brazil as well. A lot of structural conditions and issues which impact the vulnerability of people who use drugs, like gender and social and economic issues. So first of all, we have to deal with it.
Thank you. So, yeah, thank you. Thank you very much for your brave presentations, because, I mean, we went all over the world, and you know, Andres, like addressing consent, which I said before, it's one of the hardest topics to talk about. But then, Karin, you taking us to Brazil, and you take the effort to put chemsex on the agenda, and even though you are struggling with getting it going, you are doing it. So thanks for that. And then Stephane, you with the beautiful data, and I hope and I know that in Taiwan there are organizations who can pick up on that as well, because there is chemsex support in Taiwan. Dawie, thank you for pointing out the socioeconomics, and that it's not just like middle class or even maybe higher class people who do chemsex, but that it is in every layer of the population, and that needs to be addressed as well. Then we have Yasir in Pakistan. I applaud you, Yasir, for the extremely difficult situation you find yourself in, and still you hang on. So, and having said that, ending with Yannick and taking it from a user or ex-user's point of view to see what they need, because actually we can be here as harm reductionists, being professionals, but of course it is about the people who need the support, and there are so many here as well, but all over the world. And that is why I really like the motto of this particular harm reduction conference: strength in solidarity. And you guys prove this. And then, of course, I have the opportunity to tell you that tomorrow we are also going to talk about chemsex in a workshop led by Ben Collins from Reshape. And that is all going to be about the need of integrated support. And actually, you started this, and we are going to talk on about it tomorrow. Thank you all for being here, and especially another applause for our brilliant panelists.